Hello everyone and welcome to another Part 1 question set. Let's get going. What is the difference between a promoter region and an enhancer region? Well, a promoter region is a site on the DNA where RNA polymerase and other transcription factors bind just upstream from the gene locus itself. So this is your TATA box, your TATA box, or your CAT box, CAAT box. So when RNA polymerase binds to those promoter regions, it promotes gene expression and transcription. It's kind of like a place for the RNA polymerase and transcription factors to kind of latch on and then get started. And then an enhancer region is kind of similar. It's a sequence of DNA that enhances gene expression by binding transcription factors, but it doesn't have to be upstream from the actual gene. It can be upstream, downstream, kind of nearby, far away. It can even be within an intron of the gene itself. Next, what medications are considered first line in the treatment of ADHD? So we use a lot of these stimulants. So methylphenidate is commonly used, dextroamphetamine, atomoxetine is a selective norepinephrine reuptake inhibitor. And if the stimulants cause insomnia, then something like clonidine is commonly used as well. Next, what are the signs of right-sided heart failure? What are the signs of left-sided heart failure? And what is the most often cause of right-sided heart failure? So first we're talking about right-sided heart failure. So if the right ventricle fails, it can't push blood forward into the pulmonary artery. So where does that blood go? Well, it backs up into the inferior vena cava and the SVC. So signs of right-sided heart failure would include things like JVD, jugular venous distension, and peripheral edema, maybe hepatic congestion as well. So let's talk about the left side failure. So in left-sided failure, if the left ventricle can't push blood forward into the aorta, where does that blood go? Well, it backs up into the pulmonary vein and the lung. So you get pulmonary edema, especially when lying down. So that's orthopnea. You get a lot of dyspnea and exertion. And then paroxysmal nocturnal dyspnea as well, or PND. So most of the pulmonary symptoms of CHF are from left-sided CHF. And then what is the most common cause of right-sided heart failure? You'll hear this again and again. The most common cause of right-sided heart failure is left-sided heart failure, because once that blood backs up from the left ventricle into the pulmonary vasculature, now the right ventricle has to push blood against all that extra pressure again. And the right ventricle is going to be weak and wimpy compared to that left ventricle generally to begin right. Now the right-sided pressure are normally lower than left-sided pressure, so when that pulmonary pressure goes up, the right ventricle is going to fail in a hurry. So the most common cause, again, of right heart failure is left heart failure. So in dealing with right-sided versus left-sided heart failure, I want you to remember the following. Right-sided heart failure will often result in systemic problems, JVD, edema, whereas left-sided heart failure problems result in pulmonary problems like pulmonary edema, pulmonary hypertension. All right, next question. What abnormal lab values would lead you to suspect alcoholic hepatitis? So you're going to see that ratio of AST to ALT being greater on the AST. So remember, easy to remember, this is by mnemonic a Scotch and tonic. So AST is usually higher than your ALT. Next, how many umbilical vessels are there? Which umbilical vessel has the highest oxygen content? So you've got 3 vessels, 2 umbilical arteries and 1 umbilical vein. And then which one has the highest oxygen content? Well, the umbilical vein. So in the infant, the umbilical vein, the ductus venosus, and the pulmonary artery all have higher oxygenation than the aorta. Next. What organisms are particularly known for causing infective endocarditis? Well, approximately 75% of cases are due to one of 4 types of organisms. The first, we have Staph aureus at about 30%. And then 20 to 30% are going to be viridin streptococci, including strep mutans. 10% are going to be enterococci, and then 5 to 10% are the coag-negative staph, things like staph epidermidis. Now, when you know it's endocarditis but nothing is growing on the blood cultures, you're probably dealing with maybe a Hassick organism, though we are able to find out these by culture a little bit more often, but they might still have some old questions. Haemophilus is one of them, Actinobacillus is another one, Cardiobacterium, Eikenella, and Kingella. Those are the old Hassick bacteria. But again, we can actually culture these a little bit better nowadays. Next question. A 60-year-old male longtime patient of yours comes to your office complaining of sexual dysfunction. What is the differential diagnosis? What drugs are known for causing sexual dysfunction? So sexual dysfunction is nonspecific and can be caused by a lot of different things. Questions to consider when assessing this patient are decreased sex drive, difficulty generating or maintaining an erection, early morning erections. Now, a few things to consider in your differential are going to include hormonal disturbances, thinking about low testosterone, maybe hyperprolactinemia, Depression is another big one. Diabetes, which can be associated with neuropathy and atherosclerosis, particularly small vessels. You're going to see that problem. Then there's going to be psychological and psychiatric etiology, so a lot of performance anxiety, or then maybe even medication adverse side effects can cause this as well. Now, what drugs are known for causing sexual dysfunction? Well, in general, certain antihypertensives, beta blockers, neuroleptics, SSRIs, antidepressants, they can do that. Ethanol can cause sexual dysfunction as well. Next, a 44-year-old woman is seen in the ER for shortness of breath, malaise, and high fever. Chest x-ray reveals a right-sided consolidation, and her labs reveal a WBC count of 12,000. Which organism is overall the most common cause of lobar pneumonia? What organisms are the most common causes of interstitial or walking pneumonia? So the most common one is going to be strep pneumoniae, and that's going to be your most common type there. Now, what organisms are going to be a more common cause of the interstitial pneumonia or the walking pneumonia? We'll go get that in here in a minute. So first, let's talk about the classic pneumonia. The typical pneumonia is considered to be that kind of lobar pneumonia, where you have pus that fills up the lobe, the whole lobe of the lung. The chest X-ray looks like you have kind of a densely whited out section, and you have things like fever, productive cough. Patient looks pretty sick. So that's considered typical, and that's the most commonly going to be caused by strep pneumo, as we said before. But you could also have staph, you could also have H. flu, even Klebsiella. Lots of bacteria can cause this. Remember, strep pneumo is going to be number one. Now let's talk about the atypical pneumonia. So atypical pneumonia usually presents with milder symptoms, a little bit of cough, but they're doing okay. Sometimes referred to as walking pneumonia because people are walking around with this. Chest X-ray, instead of that dense, consolidated lobar pneumonia that you see, patients are going to have kind of that patchy interstitial infiltrate. It's also sometimes referred to as interstitial pneumonia. Now, if you hear interstitial pneumonia or walking pneumonia or atypical pneumonia, I want you to think about three different bacteria. This is how it also differs from typical. So atypical pneumonia is going to be caused by Mycoplasma pneumoniae, Chlamydophila pneumoniae, formerly referred to as Chlamydia pneumoniae. And then Legionella pneumophilia is another one that causes Legionnaire's disease. And then the other thing to think about are things like viral pneumonia, things like RSV, adenovirus, influenza, especially in our younger patients. Usually they're going to present with more of an interstitial pneumonia as well. Next question. Which type of lymphoma has a presentation that is very similar to CLL and fewer constitutional signs and symptoms? So it's a type of lymphoma called small lymphocytic lymphoma, which is one of the non-Hodgkin lymphomas. So lymphoma is a cancer of the lymphocytes within the lymph nodes primarily, and there's about 40 different types of lymphoma, and we split them into Hodgkin lymphoma, which is just one type, and then we lump the other 39 types into this category called non-Hodgkin lymphoma. But one of those 49 is called small lymphocytic lymphoma, which is considered to be the same disease as CLL, or that chronic lymphocytic leukemia. The only difference is that lymphoma is in the lymph nodes and leukemia is in the bone marrow and the peripheral blood. Next question. A 30-year-old man is at an inpatient facility for opioid addiction. What symptoms might this patient experience while discontinuing opioids? So you're going to get tremor, you're going to get chills, muscle, bone pain, perspiration, so a lot of sweating, flu-like symptoms. You're also going to see a lot of yawning, which is a little weird, vomiting, diarrhea, restless leg syndrome, so they feel pretty terrible. All right, that brings us to the end of the set. I hope you learned something. I'll see you next time.